arthroscopy surgeon, we've been doing osteotomies, when I joined Dr. David Rajan, he was doing since 2002 itself. We are doing a simple opening with osteotomy with a tricortical board with an ordinary T-plate. And these osteotomies were done primarily to address the varus thrust of the knees because of neglected lateral ligament injuries. And also when you're doing ACL reconstructions, when the patients had coexisting medial joint osteoarthrosis along with parasmall alignment. And off late, a lot of arthroscopy surgeons have started doing osteotomies to protect a restorative procedure, especially when they do a meniscal repair or a cartilage repair. And they had an osteotomy as a protective procedure. And now the concept of joint preservation has come in, and just like our arthroplasty colleagues and general orthopedic surgeons, arthroscopy surgeons also are focusing, adding H2O in their armamentarium. So my approach to young arthritic knee is one to find out the source of pain. Even though we can have an obvious varus or valgus, it's very important to determine which is the main source of pain, where it is coming from. Sometimes you should be aware of this red herring concept. An MRI showing an innocuous degenerative tear, or a person has an asymptomatic varus, but the main problem lying in patellofemoral joint. And this might take that arthroscopic procedures, at least in some cases, can add to the benefit of osteotomy, which is the procedure for early medial joint osteoarthritis. I would like to highlight certain technical tips about doing these combined procedures using certain case examples. And let's go. So first of all, one has to be aware of the source of pain. From the medial side, you can have obviously a medial meniscal tear. One can also have, as you can see in the first picture, a Sonk lesion or a bone marrow edema of the femoral condyle. And as Dr. Mangal Parihar was saying, in this particular patient, the alignment was normal. I just gave him a period of non-weight bearing. It's quite all right now. One can also come across bone marrow edema along the edge of the proximal tibia, which indicates overloading of the proximal tibia. And one can also see an extruded medial meniscus. And the MRI, in some instances, can show a cartilage damage and subchondral changes both on the femur and tibial side. And you can also come across tears of posterior horns of medial meniscus. And finally, most importantly, the root tears. The root tears are very important because they cause a sudden exacerbation of the pain, very typical following a small tibial injury. And these patients typically have night pain, especially when they are turning positions in the bed. And they typically complain of one more symptom, that is when both the knees touch each other during the sleep. These patients with root tear can have a lot of pain. So these are the common medial sided pain which we come across. And the other main source of pain, which we have neglected in a few cases and had problems postoperatively, is the patellofemoral pain. Most importantly, one has to be aware of this lateral pressure syndrome. It's very easy to diagnose. You can, when you put your finger on the lateral facet of the patella, the patient can have severe pain and crepitus, and the x-rays may or may not show lateral osteophytes. And another type of pain which we see is a global patellar pressure syndrome, GPPS. And sometimes people in the middle age, when they take up exercises like cycling or walking, climbing stairs, they also develop an acute patellofemoral overload. And this kind of pain settles down with few weeks of blist. And often we come across established patellofemoral OA as well. And one should not forget that some patients can have mucoid degeneration, which can be a source of pain and restriction of movement. And in many patients who have a chronic pain, which is suddenly exacerbated, an MRI can be indicated in these kind of patients. So when coming to the osteotomy, which is done along with arthroscopic procedures, H2 is commonly done along with ACL reconstruction and meniscal root repairs, cartilage repairs, patellofemoral procedures may need to be done along with H2Os. And we don't do meniscal transplantation, but H2O is being done in abroad along with meniscal transplantation. Among these few procedures, the ACL reconstruction and transosseous meniscus posterior horn repair will require making tibial tunnels, which can interfere with your screws from your osteotomy plate. So this is an idea. This is a Tomofix plate from Evo. You can see it has got 4 screws in the proximal segment and 4 in the distal segment. And most of the screws are placed in the posterior 2/3 of the tibia. So actually, if you are doing an ACL reconstruction along with this kind of plate, you can get away with an anterior uh, tibia ACL tunnel. But when you are doing a root repair, the tunnel usually crosses somewhere between the, the anterior and the middle screw, which is at a level of a centimeter below the joint level. So one has to be very meticulous in planning your tunnel position and screw position when you are doing this combined procedures. So whenever you're doing a combined procedure, the problem with using this fixed angle locking plates is that there is very little you can do when you want to change the direction of the screws. So what we normally use when you're doing a combined procedure which requires interfering tunnels is sometimes we have to settle for this spacer plates. And these ones are from Arthrex, which have a bush locking mechanism. And here you can put the screws in any direction you want. It gives nearly 30 to 40 degree of freedom for you to place the screws. And the number of screws is also very less, 2 in the proximal segment and 2 in the distal segment. And the stability is provided by various sizes of wedges, which goes and engages the osteotomy gap. And obviously, you have to be very meticulous if you are using a titanium fixed angle locking plate. And off late, we've been using this peak plate in which there are no locking threads in the plate, but there are locking threads in the screw head. As you are putting the screw in whatever direction you want, as the screw head crosses the plate, they cut their own threads and become locked. So in other words, these plates give you a little bit freedom in modifying your screw position in case you want to change the direction of the screws if it is interfering with your tunnels of medial meniscus root repair or ACL reconstruction. It's very important to be aware of this hinge fracture. When you are having a hinge fracture, it's ordinary plates without locking mechanism. Even the spacer plates with locking mechanisms may not be a good idea because they can lead to loss of correction and failure of fixation and non-union. So if you have an hinge fracture, which you are able to recognize during the procedure, it's better to use a plate with this internal fixator concept. And especially, you can see here a golden screw, which is a cortical locking screw. In the case of hinge fractures, you have to use this compression screw to compress both these segments together. And going to a case illustration, this is a 37-year-old female who had medial meniscectomy in US. Following that, she never had complete relief. She was limping in pain. And here you can see there is a medial joint narrowing. And surprisingly, this person was advised knee replacement because of the intense suffering she had. She was unable to walk. She was limping, in fact. This was done nearly 5 years ago. So we thought in terms of leftover meniscus or a cartilage lesion. So we had things ready to do a single stage BMAC. The bone marrow was aspirated from the iliac crest and concentrated. And this is an arthroscopic picture here. You can see she had a diffuse thinning of the cartilage, which suggests she's going for an early medial joint osteoarthritis. So she had a very linear cartilage defect. All the unstable fragments were removed, and microfracture was done using a 1.1 KOR. The microfracture drills holes helps in bringing out the marrow, and also they serve as anchoring points. The saline is removed from the joint, and joint is distilled, distended with air insufflation. And then the BMAC is mixed with fibrin clot and thrombin. And as it forms a clot inside the needle, it is gently injected to cover the defect. And as you can see, as you are injecting slowly, the clot nicely forms and gets applied to the defect. All you need is to wait for a few more minutes to for it to nicely settle, and it really becomes like a plasticky gel. And you can also see that the tibial marginal defect has also been filled with the cartilage. And now we can see I'm moving the knee, flexing the knee up and down, it's still stable. And most importantly, we did an unloading procedure, medial opening wedge osteotomy with spacer plate and Ospherian wedge. She had very good improvement. following the procedure. And a few surgical tips when you are using plate. It's very important that you have to release the MCL adequately. If you're not releasing the MCL and you're opening the proximal tibia within the MCL, the tight MCL is going to increase the medial joint pressures, and these patients can have less than optimal improvement. So you can see here, the MCL is nicely elevated off the tibia, and you can use periosteal elevators very gradually. You don't have to divide it. You have to just raise it proximally and distally like a sleeve until you reach the posteromedial border. Once you reach the posteromedial border, put the knee into a gentle figure of four position, and then you divide the intermuscular septum. And then with your finger and blunt instrument, you'll be able to push the muscles away from the posterior tibial surface. And at the end, if you release the MCL properly, you should be able to put your finger all the way back, and you should be able to touch the head of fibula posteriorly. So this is an important step. If you don't release the MCL properly, it can lead after an opening with osteotomy to an increased medial compartment pressure, and you can have suboptimal result. And second step is placing the guide wire. Normally, you can see radiologically the guide wire starts from the starting point of the flare of the tibia, and then it's directed to a point between the tip of the fibula and the epiphyseal line marking of the fibula. It has to stop 10 millimeter from the lateral cortex, and on the anteromedial surface, the K wire enters a point midway between the anterior border and the posteromedial border, approximately just above the level of the pes anserinalis. As you can see here, the entire line of your guide wire is going behind the tibial tuberosity, but you should not cut the tibial tuberosity. At the same time, you should have a good amount of proximal tibia so that you can make your tibial tunnels. You can put multiple screws to have a good stable fixation. So how you solve this problem is you have to do a biplane osteotomy. You can see this is how a biplane osteotomy done. The posterior 2/3 of the tibial cut is made like this. Ideally, this cut has to be parallel to the tibial slope. And then in the anterior third, there is an ascending limb. The cut goes up at an angle of 110 to 120 degree from the cut here, and it ascends up behind the tibial tuberosity. And you can see here, this is how a cut is made. So here, the opening is done within the ligamentum patellae. So theoretically, when you're doing a medial opening wedge like this, it can bring down the patella, producing a patella infera. And if you want to avoid, or you are doing a very high level correction, some people also do a descending limb like this. So in that case, the entire tibial tuberosity along with the ligamentum patellae goes along with the proximal segment. We have not done any of the descending cuts in our series. Most of the corrections we are doing the ascending limb corrections only. One can also use a parallel guide wire like this, where you can use multiple K wires. Once again, this can give you a better idea of plane that you are parallel to the tibial slope. And also the multiple K wires will give you support to your saw so that your saw doesn't wear off. And you can also see how after cutting the posterior 2/3, you're cutting the ascending limb using a saw like this. And this is a short video of how to do a spacer plate STO. Here, the guide wire is passed, and the position is verified on the C-arm, and using diathermy, the intended osteotomy line is marked, and you can see the second plane is also marked. With an osteotomy, a gentle scoring is done. So the scoring line gives a good purchase for your osteotomy screw. And I always use a small screw, small saw blade to start the osteotomy anteriorly, and protecting the posterior surface. Nearly 2/3 of posterior cut is made. Once the posterior cut is made, you go and make the biplane cut here, and you also use osteotomies in a very careful manner to extend the cut. So this is a biplane cut being done. So once your osteotomy goes posteriorly to a point of 10 millimeter from the lateral cortex, you also release the anteromedial aspect and the biplane. Then you can gently open the osteotomy using a wedge like this. and periodically checking the C-arm using a long alignment rod. And once you open the osteotomy to the desired level, as per your pre-op planning, you can fix the osteotomy with a spacer plate. You can also use a tricalcium phosphate wedge bone graft to fill the defect. And this is how it looks after the procedure. It's very important to measure the intraoperative correction using a long leg alignment rod, but this is not a substitute for pre-op planning. I think one should follow whatever principles laid out by Mangal sir in his talk, and this is just a rough estimate, a rough verification. You should always go with your pre-op planning, and there is no role for eyeballing. And more we understand about osteotomy, we should not be eyeballing these corrections anymore. So once again, if there is a hinge fracture which is recognized during the surgery, one can manage by using a strong angularly stable locking plate like this. And you have to use a compression screw in this first distal hole, which can compress these two segments together so that you won't lose correction later in the post-operative period. And this is another example of a 47-year-old female. You can easily see both the knees are looking very bad. In fact, the right knee looks very bad, but she had a lot of symptoms on the left side. And one can also see that even she has a little bit of patellofemoral changes as well. And she was suggested knee replacement, but then we had a good discussion with her, and we planned for an arthroscopy and proceed in this patient. And once again, a long leg views were taken. You can see, and we also routinely keep a 3 centimeter ball, metal ball here for verification of a magnification. And you can see the alignment, the weight bearing line is going for medially, and then planning has been made to correct the osteotomy here. And before we go to the technique of root repair, generally, when there is a varus deformity with reasonable cartilage, I prefer to do osteotomy along with medial meniscus repair up to 55 years of age. If the patient is not obese, I can extend up to 60. And even if I had to do a root repair above 60 years, I do root repair alone, but I don't do this extensive osteotomy. But I protect them with unloading brace and anti-osteoporotic treatment. The most important thing when you do a root repair is visibility and access. So you have to release the MCL by doing a pie crusting percutaneously. And one has to assess the quality of the tissue available and how easily it can be reduced. I normally use 3 number 2 fiber sutures, and then I prepare the footprint. I park the sutures in the portal and prepare the footprint, and then go to the osteotomy. Once I open the osteotomy to the desired level, I fix the distal screws and the proximal posterior screw. Then you go back and do the scopy. Now by using appropriate jigs, I do a 4.5 millimeter tunnel, but I leave the drill bit in place for root repair, leave the drill bit inside you, and then come out to the open procedure and place the proximal anterior screw, skipping the drill bit, so that I know that the threads which are going to come out through the tibial tunnel are not going to be abraded by the screw threads and get cut. And then we bring down the sutures distally out to the anterior medial surface of the tibia and tie over the button. So this is the strategy for doing a medial meniscus root repair along with osteotomy. So this is a patient. This is intraoperative. As you can see, there is nearly 40% loss of the tibial side cartilage and nearly 70% loss of the femoral condyle cartilage. But as Dr. Mangal sir told, the younger the patient, more extended will be your indication. So in this case, we wanted to save her knee at any cost. So there was a root radial tear, but then the root could be brought to the position. So this is a scorpion device. I prefer to load the device needle with a 0 fiber wire. I don't load it with a thick fiber wire in case it doesn't break the needle. So with that 0 fiber wire, you place the sutures in the peripheral third of the meniscus where you have longitudinal fibers so that the chance of getting cut through is less. And then the loop is brought out. Now it is loaded with a thicker fiber wire. As you can see, the thick fiber wire is loaded. Similarly, you place another one just medial to the first one. Now a 0 fiber is going, then it is relayed with a thicker fiber wire. And now at this stage, A jig is used to make a tunnel, and it's very important to remove some cartilage so that there will be a bit of raw area for this root to heal as well. And you can see I'm using the burr to create the raw area as well here. And all the sutures are fed into the transtibial tunnel, and they are retrieved using a suture retriever. The second pair is going inside now. The third pair is being fed and taken out. As you can see, as you pull on the meniscus with multiple sutures, the extruded meniscus is brought back to the joint, and it is fixed over an ABS button or a pillar post on the tibial side. And then you go on to tie them, and this is how we do a combined. And it's very important thing is to leave the 4.5 millimeter tunnel in the tibia. Then you put your screws, avoiding interference of or coalescence of this screw with the tunnel. So this is the postoperative X-ray of the patient. You can see the postoperative line is coming slightly on the lateral tibial spine. Probably we would have wanted it to go a little bit more laterally to the Fujisawa point because of the extreme, but she was okay for 2 years. And then we did this one. The right knee also was operated, but in this case, the right knee we were able to correct it to the Fujisawa point. But she was able to recognize the valgus in the first post-operative day, and she was asking questions why my leg is bent. So unless it is really important, one should not overcorrect. But in this case, we were justified because of the extensive cartilage loss on the right knee when compared to the left knee as well. And someone will ask why we have to do root repair along with H2O, why not H2O alone? And this is a case which will prove that these procedures can have additive effects. So this is a 54-year-old doctor who came to me with a right knee pain, but the left side I have already operated 5 years ago. You can see she underwent isolated root repair. Then I suggested her for a second stage H2O after it heals, but she never came. After 2 years, she comes with a right-sided root avulsion. You can see the extruded meniscus, the bone marrow edema. At this time, I was doing combined procedures, so I was able to do osteotomy with a root repair. You can see the button, what it was used for root repair. And even now, after 5 years, the left knee is symptom-free. That indicates to some extent, at least in some patients, the root repair can work. And we have a different series of patients, above 60 up to 74, whom we have done root repair without osteotomy, but they've been protected with unloading brace for time and again, who are having good results. So I think, in my opinion at least, both these procedures, if done properly, can have additive benefit to the patient. We'll go back to the first patient who underwent the bone marrow repair on the left side. Now, 3 months ago, she came to me. This is 5 years after follow-up. The left knee is doing all right. She was able to go back to work and all, but she complains of right knee pain with repeated effusions. I have to aspirate the effusion 2 times. She underwent a lot of physio muscle stimulation. The pain was mostly on the, I was expecting pain to be on the medial side because of the varus alignment, but the pain was mostly on the patella, on the lateral aspect of the patella. So I explained to her whether we had to go for an osteotomy or we want to go for a diagnostic procedure, but she was not willing for an osteotomy. She wanted to have more time, so we did a taping to address the lateral tibial pain. So this is an excellent technique which you can use in your clinic. This is called a McConnell's taping, which shifts the patella medially. It unloads the lateral aspect of the patella. And if the patient gets good improvement, and these patients will respond very well to lateral release procedures like lateral release or lateral retinacular lengthening. And all you need to use is the fixomal tape, which is applied by the BSNL. This is not a flexible tape, this is a rigid tape. The tape extends from the lateral border of the patella to the hamstrings region. And the tape is divided into 3 segments. The first third is applied without any tension on the anterior aspect of the fibula, on the patella. And then the patella is pushed medially. And then the middle segment is applied onto the skin. And once again, the last third is applied onto the hamstring area without any tension. If you're using too much tension, the patient can have skin peel off And a similar length of tape is taken with a slight overlap. It is applied to the inferior half of the patella. Similar, 1/3 is applied without tension. The middle third is stretched. So this patient had very good improvement after taping. And in fact, she was using taping on her own, which allowed her to go to work. Because the pain was not sitting down, we went and did a diagnostic scopy. The medial compartment, somewhat similar to the opposite knee, there are grade 3 changes in the medial femoral condyle, which was addressed by shaving and also smoothing of the fibrillations with the radiofrequency probe. And she also had this kind of osteophytes on the medial femoral condyle, which were debrided. And one can also see a lot of synovitis happening, which was causing the recurrent effusions. Coming to the patellofemoral pain, it was looking innocuous like this, and there were a lot of synovitis in the suprapatellar fossa and also in the lateral gutter. So one has to remember the peripatellar synovitis is a very important cause of lateral patellar pain, which was debrided in this case. And what we found out was a small blister like this, and you can see the entire cartilage on the lateral facet was soft like this. So we didn't want to scoop out and create a big raw area. What we did was just shrunk the cartilage blister using radiofrequency probe. And then we tried to unload the overloaded lateral compartment by doing a lateral release. So this patient was followed up regularly. As you can see, the entire lateral facet is smooth, it's soft, looking like a blister here. And she had very good improvement after this procedure, but the effusion kept on happening, which we thought was due to the cartilage debris being generated by the worn out cartilage. So we did a second stage procedure, curated all unstable cartilage lesions, did a BMAC repair, and then did an osteotomy. So this is a case which can show that in addition to the obvious varus and medial wear, the pain can actually come from some other area like patellofemoral joint as well. This is a 61-year-old female, came with a patellofemoral disease. And this is also an important technique which you can use when you're correcting varus alignment along with severe lateral sided pain. So in this case, we are doing a lateral retinacular lengthening, which, unlike release, reestablishes the control on the lateral side as well as medial side. The medial retinaculum is divided in 2 layers. As you can see, this is a superficial layer being divided, and it is reflected down to around 2 centimeters from the margin of the patella. So this is a superficial layer being reflected. So once you are able to reflect it for a distance of 2 centimeters from the patella, you make another cut, much more medial cut in the deep layer. And now the deep layer is divided, exposing the synovium there. Now synovium is divided. The synovium, whatever synovitis you are seeing on the lateral side, you can divide. And then the retinaculum is slowly reflected off the anterior surface of the patella. Any osteophyte is divided, and the synovium is buzzed with diathermy. As you can see, the osteophytes are being trimmed with the, and then the knee is flexed at around 80 degrees, and the superficial and deep layers are sutured in a relaxed position. And next case, a severe osteophyte of the patella. You can see there is a huge beaking lateral osteophyte is there. Once again, we've opened it. Also, any osteophytes on the trochlea is debrided. Now the anterior layer is reflected, and this is really a huge osteophyte, and the saw is used to cut away nearly a centimeter of the lateral facet of the osteophyte along with part of the lateral facet, and that is the remaining patella. And this we have been able to do along with HTOs also, and in some cases as an isolated procedure to address the patellofemoral pain above 50 years of age. So coming to the ACL reconstruction along with HTO, I won't be showing any cases because the principle when combining with the root repair and HTO are the same. Primarily they are done when you're doing ACL reconstruction in a medial joint osteoarthrosis along with varus deformity. Whenever there is a failed ACL, because of an increased tibial slope, which is responsible for nearly 11% of failed ACLs. One can also combine revision ACL with a slope correcting high tibial osteotomy. And third indication would be doing an osteotomy to correct any varus threat which is coming from a chronic PCL insufficiency. And my preferred graft is a hamstring graft. The steps would be graft harvest, do the femoral tunnel first, do an osteotomy, fix the osteotomy plate, distal screws, and proximal posterior screw. Then you make the tibial tunnel, leave the drill bit inside as you can see in the picture, and then drill the proximal anterior screws, avoiding the drill bit. And once you fix the osteotomy like this, remove the drill bit, and then you pass the graft and do fixation. Sometimes the interference screw may not be a good idea in the tibia, especially when the screws are crossing close by. One has to be ready to use additional tibial fixations also in these situations. And you can see here, this is a revision ACL scenario where I'm using an osteotomy to correct the slope. When I start the scope, there are two parallel KOS in the proximal and distal segment of osteotomy. And when you're opening the osteotomy, you open in such a way that they end up converging like this, so that you actually decrease the tibial slope, which is helpful for at least a percentage of failed ACLs in which an increased tibial slope is the cause of failure. So how much correction would you grow? When you are coming across an established cartilage damage and extensive medial joint osteoarthritis, it is advisable to go to the Fujisawa point. And in these situations, good valgus correction of 7° or 8° have shown to improve the survival of HTOs. But if you're doing osteotomy, especially in young patients with focal damage, you want to protect your cartilage repair, you want to protect your meniscal tear. And also when you're doing asymptomatic corrections, always better to achieve a mechanical valgus of 2°. And any amount of valgus may not be tolerated by these patients, and especially it would also preclude any sports activities. And if you're doing osteotomy for slope correction, you don't have to valgase, you can bring it to neutral or just beyond neutral. And you have to focus most of your efforts on correcting the slope. One should also remember that a medial opening wedge osteotomy tends to increase the slope, and a lateral closing wedge osteotomy tends to decrease the slope. And some surgeons in Europe, they are preferring a lateral closing wedge osteotomy for revision ACLs right now. And we don't have any particular experience with that technique. To conclude, one has to remember to identify the source of pain and try to address as much sources of pain as you can find. And especially if there is an acute exacerbation of a chronic medial joint pain, there could be something else happening. Arthroscopic procedures can be combined with osteotomy. They can improve, they can have an additive effect, and possibly can prolong the survival of osteotomies. It's more like I want to bring osteotomy to the arthroscopy surgeons than bring arthroscopy for the osteotomy surgeons. And every arthroscopy surgeons, in my opinion, should be aware of this procedure and should question themselves whether a particular patient who comes with a meniscal tear or early wear and tear should benefit from this procedure. With this, I conclude that both these procedures can improve the benefit to the patient. A lot of papers have come supporting the combined procedures here. And once again, I thank OSAP for organizing this event. And Naresh, I conclude my talk, and we're open for any questions and discussion.